Hello everyone. Now we'll be discussing the ECGs in chamber enlargements, that means the atrial enlargements and ventricular enlargements. Some of these points we have already discussed. We'll just try to compile them and learn something more. Before proceeding further, I must tell that whatever PPTs I am using here or whatever I am writing, all these PPTs I am putting as a link in the description. So if you want to download the PPT, you can in the description you can just click on the link. It will lead you to a Telegram group. From there you can download the PPTs. Okay, so first of all, we'll start with the left atrial enlargement. I have told the left atrial enlargement will be seen. So basically, the atrial enlargements you have to see the P wave morphology, and P wave morphology has to be seen in lead 2 and lead V1. Normally, lead 2 will have a upright P wave, and V1 will have a biphasic P wave. So what happens in left atrial enlargement? We all know that the second part of the P wave, if this is a normal P wave in lead 2, the second part, that means this part is representing the left atrial depolarization. Similarly, in V1, where you get a biphasic P wave like this, the second part, that means this part is actually representing the left atrium. Okay. So what will happen in lead 2? In lead 2, you'll get a bifid P wave. This we have already discussed in our previous basic ECG basics videos. So bifid P wave and the distance between the two peaks will be more than 40 milliseconds. Okay, so bifid P, distance between the two peaks will be more than 40 milliseconds, and it will be broad. It will be a broad P wave, that is more than 110 milliseconds or more than 120 milliseconds. Okay, so these are the finding in lead 2. What will happen in lead V1? In V1, the second part, this second part is affected. So the second part will become wide and deep. So the second part will become wide. Wide means more than 40 millisecond. That is more than one small box. And also it will become deep. That means more than or equal to 1 mm deep. Okay, so this is the finding in lead 2 and this is the finding in lead V1 for left atrial enlargement. Something called Morris index. Morris index. That is for left atrial enlargement calculated in lead V1. Here you have to multiply the depth with the width or the duration. Depth into duration. Duration in seconds and the depth in mm. If it is more than equals to 0.04, then that suggests left atrial enlargement. As you can see in this example, if it is more than 40 milliseconds is 0.04 seconds. 0.04 into 1 mm deep, so into 1, that is becoming 0.04. Okay, so anything 0.04 or anything more than that, that represents left atrial enlargement, and this is known as the Morris index. Now, second part is right atrial enlargement. This also we have discussed. Right atrial enlargement in the lead 2, you will get a tall peak T wave, also known as the P pulmonal. So here the amplitude of the P wave will be in the lead 2, it will become more than 2.5. Okay, lead 2 amplitude will be more than 2.5, and lead V1 amplitude will be more than 1.5 mm, more than 1.5 mm. Okay. So P wave amplitude more than 2.5 mm, lead 2, 3 AVF. Okay, so all the inferior leads. If you want to learn more about it, you can see the basic lectures also. Here you can see in the lead V1, see the first part is affected. Okay, right. In so if you see this image, here the second part is actually representing the left atrium, and the first part is representing the right atrium. So right atrial abnormalities will be represented in the first part of the P wave. Okay. So I hope this is clear. In the V1, amplitude is more than 1.5 mm. In lead 2, amplitude is more than 2.5 mm. What happens in biatrial enlargement? The combination of both the findings will be there. So as you can see in this image, this is the biatrial enlargement. We are getting combination of both the abnormalities. Okay, so nothing great in this. Now coming to the ventricular hypertrophy, first of all, start with the left ventricular hypertrophy. The criteria that we commonly use is Sokolow-Lyon criteria. Sokolow-Lyon criteria. It's also some points I have already told you. Sokolow-Lyon criteria. You have to see the S wave depth of S wave in V1 or V2, whichever has the maximum depth, plus height of R in V5 or V6, whichever has the maximum height. It should be more than 35 mm, more than equal to 35 mm to call it as left ventricular hypertrophy. Okay, so depth of S in V1, V2, height of R in V5, V6. Of course, left ventricular depolarization is happening laterally towards the V5 and V6. That's why it will produce a positive wave in V5, V6, and it is happening opposite to the V1, V2. So that's why it will produce a negative wave in V1 and V2. So that's why we are taking S of V1, V2 and taking height of V5 or V6 to represent the ventricular hypertrophy, left ventricular hypertrophy. Now this is the classical Sokolow-Lyon index that you have to remember. Apart from that, there is one more criteria in the Sokolow-Lyon index, that is AVL. R in AVL more than 11. If this criteria is not fitting, we can always look for check for this criteria also. This is also a part of Sokolow-Lyon criteria. If you see this ECG, this is the S of V2. You can see this is 1, 2, 3, 4. 4 large boxes, that is 20 small boxes. Around 20 small boxes. In V5, you can see the R. It is around 1, 2, 3, 4, 5, 6, 7. Around 35 small boxes. So combining it is definitely more than 35 mm. So this is satisfying the criteria of left ventricular hypertrophy. But whenever there is LV strain, usually this left ventricular hypertrophy may be associated with LV strain pattern. And I have already told you, whenever you are finding a strain pattern, you will get ST depression and T inversion. You will get ST depression and T inversion along with that. Again, here you can see T pace and tall R in V5. If you combine them, definitely it will be more than 35 mm. So that is satisfying the criteria of LVH. Along with that, you can also see there are strain pattern. There is strain pattern, ST depression, T inversion, ST depression, T inversion. Okay. And along with that, if you look at the axis, lead 1 is positive, lead AVF is negative. So it is lead 1 is positive, AVF is negative, so it is left axis. So there is left axis deviation also. So these are some of the associated findings. Along with the LVH, most of the times you may get this strain pattern. You may get this left axis deviation. So these are the associated findings along with the left ventricular hypertrophy. Okay. So left axis deviation and the strain pattern. And of course, from V1 to V3, you will get ST elevation, because here there is a predominant S wave. So you will get a discordant ST elevation. Okay. So in strain pattern, in the lateral leads, strain pattern lateral leads will show ST depression, but otherwise the other leads like V1 to V3, these are right-sided leads. Here the predominant vector is downwards, so you will get a ST elevation. Okay, in the lateral leads you will get a ST depression. So both the things are possible. But if someone asks you what is strain pattern, that means it has to be ST depression is T inversion. And these are all the associated findings with LVH. Now, what are the other criteria? Other criteria, you have to just remember the names. One is Romhilt and Eves. Another one is Cornell voltage criteria. Another one is Cornell product. Another one is total QRS voltage. In total QRS voltage, you have to add all the amplitudes of all the 12 QRS amplitude of all the R waves in the 12 all the 12 leads, and the normal voltage averages 129 mm with 175 mm as the upper limit of normal. So if you are adding up all the R wave voltages in all the leads, It should be less than 175. If it is more than 175, definitely that is LVH, and that is the total QRS voltage criteria. In corneal voltage criteria, it is the R in AVL and S in V3. In corneal voltage criteria, R in AVL and S in V3. If it is more than 28 mm in male or more than 20 mm in females, that is also satisfying the criteria of LVH. Corneal product is nothing but the total QRS duration multiplied by the corneal voltage. It should be less than 2440 milliseconds. Okay. So these are some of the other criteria, but you need not remember all of them. Just remember the names: Rombilton is corneal voltage, corneal product, and total QRS voltage. Now coming to the right ventricular hypertrophy. Right ventricular hypertrophy, I have told you, you have to look at the V1, where you will get a R wave that is more than 7 mm, or R by S more than 1. Okay. Also, you will get in V5 or V6, you will get a predominant S wave, But always remember, QRS duration has to be less than 120. It has to be less than 120 or normal QRS duration. Why? Because if QRS is wide and you are getting a similar finding, this may satisfy as a right Bundleman's law. So to remove that confusion in the diagnostic criteria itself, many times the textbooks write QRS voltage, QRS duration along with this uh, lead criteria. Okay. If you see here, you can see dominant R in V1. There are so many causes of dominant R in V1, and one of them is right ventricular hypertrophy that we have already discussed. And you can see R wave is definitely more than S, and R wave is definitely more than 7 mm. You can also appreciate that in V5 and V6 there is a prominent S wave. Definitely QRS duration is normal, less than 120 milliseconds. Okay. Axis. If you see the axis, lead 1 is negative, AVF is positive. So lead 1 is negative, AVF is positive. So axis is in this quadrant, that is right axis deviation. So right ventricular hypertrophy, similar to left ventricular hypertrophy, it can also cause the axis deviation, that is right axis deviation. These are the associated findings of right ventricular hypertrophy. Then coming to types of right ventricular hypertrophy, some of the textbooks like Balthazar's ECG book have described types of RVH. So types of RVH, it is actually three types: type A, type B, and type C. Type A, type B, and type C. Type A, remember, this is the most common type and the classical type that we have described. Here R, like prominent R in V1 and V1 and V2, and prominent S in V5 and V6. Here the axis is usually right axis. Here the axis is usually deviated towards the right side. So most of the times you'll get a right axis deviation. So axis more than 110 most of the times. And the causes include pulmonary stenosis or severe pulmonary hypertension. Type B. Type B, here what happens? R wave is more than S in V1. That means both R and S are present, but R is more than S. Here V5 and V6 will be normal. That means the prominent S that we are getting in type A, prominent S in V5 and V6 that we are getting in type A will not be present in type B. In type B, V5 and V6 will be normal. Here axis is around 90 degree, so it is not deviated to the right side. Causes include, for example, mitral stenosis with mild pulmonary hypertension. The third one is type C. This is the most difficult one to diagnose. The most difficult one to diagnose. Why? Because here the R, amplitude of R is less than S. Amplitude of R is less than S. That's why it's very difficult to diagnose as RVH, the type C RVH. A very important finding that you will get is lead 1 sign. I'll show you in the ECG what is lead 1 sign. Lead 1 means the lead 1 will show a straight line. Lead 1 will show a straight line. Classical example is COPD and acute pulmonary embolism. COPD and acute pulmonary embolism. Okay. Now, if you see the ECG, you can see the type A is classical RVH that we are describing. Prominent are in V1, prominent S in V5, V6. And if you see the axis, here the axis is right deviated, right-sided. Right-sided axis because lead 1 is negative and ABF is positive. Type B, I told you in V1 and V2, you will get R and S both, but R will be more than S. R will be more than S. And then V5 and V6, you can see the S wave is not prominent, S wave is normally present. Okay. The most difficult one I told is the type C. Here both, here you can see R is definitely less than S. R is definitely less than S. But what you can appreciate is the lead 1 sign here. That means the lead 1 is like straight line. So this is type C, which is classically described in COPD. One more thing you can definitely appreciate that the P wave is tall. P wave is tall. That is also known as the P pulmonary. So there is definitely right atrial enlargement also. The last part is the biventricular hypertrophy. Now, biventricular hypertrophy incorporates the voltage criteria of both LVH and RVH. Okay. So, when you do suspect a biventricular hypertrophy, if you see this ECG, so this is here it is not very clear, but here one thing you can appreciate that there is left ventricular hypertrophy, and if you see the axis, okay, yes. So if you put the voltage criteria for LVH, that means S wave in V1 and R wave in V5 or V6, you can definitely appreciate that this is more than 35, and that is satisfying at LVH, left ventricular hypertrophy. Now in this ECG, if you look at the axis, you can see lead 1 is negative and AVF is positive. That means lead 1 is negative, AVF is positive. That means it is right axis deviated. So axis is right axis. Right axis. So in any ECG, if you are getting left ventricular hypertrophy with right axis deviation, that means there is additional right ventricular hypertrophy. So these are some of the clues. If you are getting voltage criteria for one ventricular hypertrophy, chamber enlargement, along with that axis deviation of that of other chamber enlargement, then you have to suspect a biventricular hypertrophy. Okay, you have to suspect a biventricular hypertrophy. That means the voltage criteria for both the ventricular enlargement may not be present in the ECG of a biventricular hypertrophy. I hope this is clear. I'll explain it again. In this ECG, if you apply the voltage criteria for LVH, you are getting a left ventricular hypertrophy by satisfying the Soprol-Lyon criteria. But here you cannot apply the right ventricular hypertrophy criteria because you can see in V1 there is no prominent R wave. But if you look at the axis is right axis deviation. The axis is rightward. So we have to take it as biventricular hypertrophy, and right ventricular hypertrophy is causing the right axis deviation, and the voltage criteria is satisfying the left ventricular hypertrophy. Okay, there is one more phenomenon that we have to remember. In case of biventricular hypertrophy is Carr-Schwarzel phenomenon. That is large biphasic QRS complexes in V2 to V5. Okay, so the ECG I have not shown here, but you have to remember this is also a finding that you may get in patients with biventricular hypertrophy. So in V2 to V5, we will get QRS complexes like this. Okay, so these are large biphasic QRS complexes in V2 to V5, and this is known as Carr-Schwarzel phenomenon. And this is also a finding in biventricular hypertrophy. This is also a finding in biventricular hypertrophy. This is classically described in patients with ventricular septal defect, where we get a biventricular hypertrophy, and the ECG will show this Carr-Schwarzel phenomenon. Okay, so that's all from this ventricular enlargement topic. Thank you, and also look at the description for the link to download the PPT.